Hi, everyone. I think we're going to go ahead and get started. We're here for the first of two breakout sessions for precision treatment and cancer care, present and future. My name is Jill Lee, and I'm a pediatric nurse practitioner that works in our childhood cancer survivor program. And I'll be moderating this session today. Before I introduce our speakers, I just wanted to set a few ground rules for our sessions today. The goal of this session is to help you feel better, more hopeful, and not so alone. We will not talk about any specific diagnosis, treatments, or give any medical advice. We won't discuss side effect management, and we are not here to discuss practical problems like work or medical system navigation. If you are joining us online, our virtual moderator is Heidi Eschenbacher, and she's monitoring the chat, so please feel free to add comments or questions throughout the presentation. We will have some time at the end for question and answer. I have the pleasure of introducing our two incredible speakers, Dr. Emmanuel Antonarakis and Dr. Justin Hwang. Dr. Antonarakis is the Clark Endowed Professor of Medicine and a genitourinary medical oncologist with a particular focus on recurrent and advanced prostate cancer. He conducts clinical and translational studies to bring new therapies to patients with prostate cancer. Dr. Antonarakis is also involved in mentoring fellows and junior faculty in the clinical care of genitourinary cancers and the development of translational research strategies related to prostate cancer. Also presenting today is Dr. Justin Hwang. Dr. Hwang is currently an assistant professor at the University of Minnesota Division of Hematology, Oncology, and Transplantation. After completing his chemical engineering undergraduate degree at Carnegie Mellon University and biochemical graduate degree from Tufts, he completed his training at the Dana-Farber Cancer Institute, Broad Institute of MIT, and Harvard. In his time at the University of Minnesota, he leads collaboration and consortium studies with other cancer centers such as Dana-Farber Cancer Center, Johns Hopkins University, National Cancer Institute, the Masonic Cancer Center, and industry partners. Please welcome Dr. Antonarakis and Dr. Hwang.
Good morning, everyone. It's my pleasure to be here. You know, all of us, just like you, have many things that we're doing in our lives on the weekends. And I think I got here with 4 minutes to spare because my wife was working this morning and I had to take care of some stuff with my kids and then get in my car, and I didn't anticipate the road closures. And some exits that were not listed on my app as being closed were closed, but we all made it in time. So Justin Hwang and I will introduce a very interesting topic to us, which is precision treatment in cancer care. This is sometimes called precision oncology, or more broadly known as precision medicine. And what we decided to do, given that it is a Saturday, and we didn't want to make this didactic, we wanted to make this interactive. And also hearkening back on something that one of my mentors once told me, which is you should never have more than 4 words on each slide. And if it's a weekend, you should cut that by half. So each of my slides is going to have 1 to 2 words, and it's going to be more to prompt me to remember the sequence of things that I want to talk about. If you are expecting a lot of technical things from me, you'll be disappointed. Justin will get a little bit more technical than me, but he will also describe the applications of all the genetic and genomic research. How does that actually make a difference to our patients? And I'd like to begin. Justin, any words you want to say at the start? Okay. He'll introduce himself when his turn comes up as well. All right. So a lot of us have heard of the term genetic testing. There can be some confusion about this. And then there's a lot of other terms that we're going to discuss that sound a little bit like this, but they're not exactly the same. So I just wanted to start with some definitions to set the scene of what we're talking about. And these are all things that are necessary to understand before even talking about what precision oncology or precision medicine is. If you don't understand these terms at a lay level, then the other conversations will be hard to follow. And I'm trying to set up Justin for success so that he doesn't end up confusing all of you, although there's probably coffee somewhere that you could grab in the meantime. All right, genetic testing, obviously the origin of that word is the word gene, right? The first 4 letters, gene. And we used to talk about genetic testing a lot back in the days where we were analyzing one gene at a time, or maybe 2 genes, or 5 genes, or 10 genes. And one of the first cancer genes of all time was BRCA1, followed by BRCA2. Those were discovered in the early 1990s. And in 1997, the words BRCA1 and BRCA2 started to become more well-known, not because of anything that me or Justin or any of the medical community was doing, but it was because of Angelina Jolie. So one celebrity can make such a huge impact on population's understanding of genetics. And in 1997, Angelina came out publicly and stated that she had been tested for the BRCA1 gene and she was positive. And I don't know if anybody remembers the 1997 Time magazine. She was on the front cover of Time magazine. And at the age of 37, she had a double mastectomy. Now, why did Angelina have a double mastectomy for the BRCA1 gene? She herself did not have a history of cancer. There was no cancer in her body. But Angelina's mother and Angelina's sister had both developed breast cancer in their 30s, and her mom had died recently in her 50s. And because of that family history and the research at the time that there's some cancer genes that predispose people or families or individuals to getting cancer, she got tested and she was positive. And I think that made such a huge impact on the word genetic testing in the field, because after that, people started to hear about it and know about it. And it turns out that that gene, which was named BRCA1 because it was a breast cancer gene, BR for breast and CA for cancer, actually is more common in men with prostate cancer than in females with breast cancer. So it was actually a misnomer. Should have been called PRCA1, prostate cancer 1. But of course, the name stuck. And also, females and breast cancer advocacy groups have historically done a much better job than men and male advocacy groups and prostate advocacy groups. So we were like a decade behind the breast cancer group. So genetic testing refers to testing a small number of genes at one time. So, when you get past about 10 genes, the word genetic testing is no longer relevant because you're testing so many. And we had to actually invent a new term. And this term is about 10 or 15 years old. And it's not genetic testing anymore now, it's genomic testing. And the word gene in genetic testing has been replaced with the word genome, the human genome. And what does that mean? So the human genome is not just one gene or 2 genes, it's the entire genetic code that every human being is born with. If anybody had to take a guess in the audience, does anybody know how many letters are there in the human genetic code? Is it 1,000? Is it 10,000? Is it 1,000,000? Is it 1,000,000,000? Does anybody have a rough idea of how many letters are in each human being's genetic code? Justin, I'm not going to put you on the spot. It's about 6 billion. So you get 3 billion letters from your mother and 3 billion from your father. So instead of saying we're going to be testing one gene at a time, each gene has about 2,000 to 4,000 letters. Multiply that by whatever number is needed to get to 6 billion. It turns out that human beings have about somewhere between 20 and 22,000 genes. So 20 to 22,000 individual genes. We only know what 1% of those genes do. And that just blows my mind. So in 2025, all of modern science around the world, not just in this country, not just at University of Minnesota, we only know the function of about 1% of the genome. That's just mind-boggling to me. So I was talking to my 11-year-old son the other day, and we were talking about Nobel Prizes, and I told him that there are 4 individuals that have gotten the Nobel Prize twice. There's no one that has gotten the Nobel Prize 3 times, but there's 4 individuals that have gotten it twice. And of the 4, 1 was a female. It was Marie Curie. And the other 3 were males. And my son says, my goal, Dad, is to be the first person to get the Nobel Prize 3 times. And I said, wow, okay, that goal is not lofty enough. You should aim higher. And then he said to me, do you think if somebody discovers what 10% of the genome does, that would be enough to get the Nobel Prize? He's like, we only know 1%. What if is 10% good enough, or does somebody have to discover 50%? And I said, man, if one single individual discovers the other 10%, that would be a Nobel Prize, at least one. So we have a lot of work to do, but we are choosing at the moment to sequence the entire genome of many, many cancer patients, even though we only currently understand about 1%. And part of Justin's job is to take all the information that we gather and store it somewhere, because one day, that one day might be in 5 years, it might be in 10 years, all that information that we currently don't know what to do with might actually be valuable. So why not capture it now? Because the cost of sequencing the 6 billion letters of the human genome is down to about $1,000. You know, the first human genome, which was sequenced in 1990, took about $10 million to sequence. It was one person's genome. And now we can sequence an entire human genome in about 2 to 3 weeks for about $1,000. And most insurance companies are paying for it for cancer patients. So if you're a patient that has a cancer, almost any cancer, we can take a biopsy of your tumor or use a previous biopsy that was already conducted to make the diagnosis of your cancer, and we always have some tumor left over. And we can actually, what we do here is we collaborate with for-profit companies that do this sequencing faster and cheaper than we do it here at the University of Minnesota. But we have arrangements with these companies whereby any patient who is our patient, we get access to all the raw data from that patient's genome. So it's kind of a win-win for us. In terms of the patient and his insurance company's perspective, that is covered as a medical requirement of their care. And then once that test is done, we actually can store all the information, even the information that we don't know how to use currently in 2025, in Justin Hwang's very, very complicated supercomputing servers, and he'll talk about that in a second. So genomic testing now means you're going from one gene at a time or 10 genes to all 20 or 22,000 genes in the human genome. And at the moment, we're using a fraction of that information, but in the future, it might change. Now, where does human DNA come from? I want to make two distinctions here because this is important. The first is what we call the germline DNA. This is also sometimes known as germline genetic testing or germline genomic testing. The germ cells are the sperm and the egg. So the germ cells refer to genetic mutations that occur either in the sperm or the egg, and they are passed on to that individual. And then those genetic mutations, not all of them are harmful, some of them could be neutral, some of them could be beneficial, are then present in every single cell in that person's body. So they're present in the heart, they're present on the skin, they're present in the small intestine, they're present in the eyeball, they're present everywhere. So if you're born with a germline genetic mutation, it's not always harmful, as I mentioned, it can just be a variant. Those genetic alterations are present in every cell in your body. In cancer, this becomes relevant because we talked about the BRCA1 and BRCA2 a moment ago. Those are examples of germline mutations. Those are examples of mutations that are inherited, often from a parent, and sometimes we may not even know which parent that could have come from. And importantly, these germline mutations can be passed to the person's offspring, their kids. So germline mutations, if they are discovered, they're not only important for that patient's cancer journey because they are giving us an indication of that person's risk of one or more cancers, but in addition, there are family considerations with respect to that person's children, but also their siblings. If you have a germline mutation yourself, there is a 50% chance that each of your siblings will have it, and there's a 50% chance that your kids may have it. So if you have a germline BRCA1 mutation, you have 4 kids. By chance alone, 2 of the 4 will have it. Each one is a 50-50. So whenever we find these mutations in the oncology clinic, we can't just focus on the implications for that patient. We have the obligation to tell them that this may have implications for their kids. Maybe they haven't had kids yet, or they might be planning kids. Or if they do, then their children may want to get tested for that specific genetic mutation. The second type of genetic mutation is called a somatic mutation or somatic genetic testing. The word soma in Greek means body. So these are mutations that occur in the body, in any organ, but they are not inherited, and they cannot be passed to your children. And we can actually determine from these genetic tests whether a particular mutation is a germline one or a somatic one. And that's really not a conversation that most oncologists have with their patients. They might just say, we took your breast cancer sample and we found a BRCA1 mutation. That information is not enough, because that BRCA1 mutation could be inherited, it could be a germline, or it could actually be a somatic. It's possible that you were born without any BRCA mutations, and then during the course of your life something happened, or you were exposed to some environmental exposure or just bad luck, and all of a sudden one of your cells in your normal breast or your normal prostate or your normal colon developed a spontaneous mutation after you were born, not inherited, and then that mutation triggered the cancer. The important thing about that distinction is a patient that has a somatic genetic mutation in their cancer, they do not have to worry about passing that to their kids. It's impossible. They cannot pass that to their kids. So oftentimes, those patients might breathe a sigh of relief because the doctor says you've got a BRCA mutation, and then they say, but don't worry, it's not inherited, and you can't pass it. So it's very important that oncologists become educated. When I went to medical school, none of this stuff existed. We never learned about this. And, it's necessary, I think, for doctors to know these things, especially oncologists. Now, the next thing is, what is an NGS report? Justin and I talk about this a lot. So next generation sequencing, next generation sequencing. In the old days, when we used to sequence a human genome, we had to start at the beginning and sequence it like as if it was a linear segment and then go right from the beginning all the way to the end. And that took a very, very long time. It was very, very, very expensive. And then there was a quantum discovery with genetic sequencing, which was if you take the human genome and you chop it up into tiny little pieces, each piece is like 10 or 20 or 30 letters long, and you just sequence each of those small fragments, and then you stitch all the fragments back together by looking for the overlapping segments. You can actually do that much, much faster. And that technology was called next generation DNA sequencing. So in 2025, every time one of you or one of us gets a genetic test, it's always a next generation. We're not using the old Sanger sequencing technology, as it used to be called. So a lot of times you might be in the clinic and your doctor might be saying, did we get the NGS report? Did we get the NGS report? So these are the genetic reports that these commercial companies provide to physicians that basically give them the result of that genomic or genetic test. Now, the important thing about this is you cannot create a report that has 20,000 pages in it. Okay, these reports are typically 10 to 15 pages. The first page is the most important. That's where the punchline is. And so what each of these companies have had to do is they've had to select, which of these 20,000 genes are important enough to put on that front page of the report. And they typically pick around 200 to 300 in most cases. But then the other 20,000 are ingested, transferred to Justin Hwang's Supercomputing Institute. And so again, the report is only going to have a fraction of what was discovered, and it's the fraction that we think we can interpret at the moment. And by the way, we often share these NGS reports with patients, and they look at us as if it's a different language. And since I'm Greek, I always say it's Greek to me as a joke. But they can be complicated, actually, even for physicians, let alone for patients. And Justin and I discuss these all the time because I often have to get his advice about what to do and how to interpret these as well. I also wanted to talk about the term liquid biopsy, also known as a circulating tumor DNA test, ctDNA test. So I think liquid biopsy is likely to transform the future of oncology. Up until now, the majority of our patients are getting a biopsy of a tumor using a needle or a surgical resection. So either the surgeon removes the cancer, and then we have that material there, and we do the genetic testing from that, or if the cancer cannot be removed, we often subject the patient to a biopsy, which involves putting a needle, through the skin. It's often painful. But I think the future, and we are beginning to see this already, is to take a blood sample from a patient, and that's why it's called liquid, because it's blood as opposed to a tissue or a needle biopsy. And we have developed the technology, we as a field, and here at the University of Minnesota, where we can actually look for materials that are coming from the cancer cells, but they're in the circulation. And there's two main things that we can look for. We can actually look for the circulating tumor cells, so the entire cell. If you take a blood sample from a patient, 99% of the cells in that blood sample are going to be blood cells, red blood cells and white blood cells. And a tiny fraction, 1% or less, depending on how much cancer that person has in their body, 1% or less is going to be the circulating tumor cells. So you're looking for a needle in a haystack. It turns out that this is pretty difficult to do. And by the time you try to handle those cells, the cells are very fragile, and they can sort of break apart, and they're a bit more difficult to analyze. But a quantum leap that was made more recently is that what you really want to know is, yes, it's helpful to know if they're circulating tumor cells, but ultimately you want to be able to analyze the genetic code of those cancer cells. And it turns out that cancer cells, more so than normal cells, are shedding their DNA from inside the center of that nucleus into the circulation, into the bloodstream. So even though the circulating tumor cells themselves are difficult to detect and are very fragile when you try to isolate them, it turns out that what's a lot easier to do and very clinically relevant is you can actually detect DNA coming from tumor cells and distinguish it from DNA coming from the white blood cells or the inside of the blood vessel or other normal non-cancer tissues. And these are called ctDNA, circulating tumor DNA tests. And I would say in the last 3 years, we and others have really been focusing on this technology because it's so much less invasive for a patient. And it can be done over time. Just imagine if somebody told you you have to have your prostate biopsied once a month for the next 1 year. That's 12 prostate biopsies. I mean, there's no patient that would ever accept that. But if you told the patient we're going to take 12 blood samples 4 weeks apart, that might be a lot more acceptable, especially because that patient might be getting blood tests for other reasons. So I think these circulating tumor DNA biopsies are going to revolutionize and maybe even one day replace tumor biopsies. And then the last thing I want to talk about is this thing about cancer evolution. We know that Charles Darwin first described the evolution of animal species. And it turns out that cancer evolves in a very similar way as Charles Darwin had predicted. And the whole theory of evolution, and whether you believe in the Bible or Genesis or not, I'm not going to get into that debate here because I think they're both consistent with each other. So we're not going to dispel any religious arguments here. But the thing about evolution is it only occurs when there is a selection pressure in the environment. If the environment of that species doesn't change, then that species has no reason to evolve. Okay? So a classic example, you're going to learn a lot about animal evolution today. You probably never expected that. There used to be a species called a horse, right? A horse has a relatively short neck. And it turns out that there was a period of drought where the environment for that horse became very, very hostile. And it was dry, and there were only a small number of trees in that location. And the horses had short necks. They ate all the leaves that were on the lower branches of the trees. And then many of them, they couldn't survive because there were more leaves higher up, but they couldn't reach them. And then one day, just by chance, just by genetic chance, so just by chance, one of the horses developed a mutation that caused its neck to be longer. Just by chance. And that horse now, with a longer neck, could reach the leaves that were higher up on the trees, and that horse survived. And its offspring also had the long neck gene, and they survived. So a new species called the giraffe, was invented from a horse into a giraffe. Those giraffes had longer necks. And they survived when a lot of the horses actually had died. And that's actually a true evolution of the giraffe. But that giraffe would not have had any advantage. It would not have had any reason to survive if there was no drought at that period of time in its environment. Okay, so it's these pressures in the environment that cause cancer cells to evolve. And it turns out that the therapies that we give to our patients actually cause evolution in the cancer cells. And it's kind of an interesting and a scary thing to think about, because on the one hand, we need to treat the cancer. We can't just let it evolve on its own and see what happens, right? We have to intervene. But it turns out by intervening with chemotherapy or radiotherapy or other targeted therapies, we're creating an environment where many of those cancer cells are dying, but the ones that are left behind have some advantage, have some genetic mutation or advantage that makes them resist that chemotherapy or hormone therapy or immunotherapy. And then those cancer cells that survive are able to actually multiply, divide, and then their children divide and their children. So over the course of time, the genetics of a cancer can change. It can evolve. And the right therapy for that patient, in year 1 of their diagnosis might not be the right therapy at year 3 or at year 5. Obviously, if the patient is cured, we don't care about cancer evolution because the cancer is eradicated. But in cases where the cancer might be metastatic, for example, might be persisting over time and changing over time, then it becomes important to understand the cancer evolution. And this is where the liquid biopsies or the circulating tumor biopsies are very, very important, because you might not have a mutation at the beginning that becomes acquired over time. And in some cases, rarely, you may have a mutation that's present and then disappears. And in the context of precision medicine and precision oncology, where we are trying to use drugs that target specific mutations, you might want to know that, because you don't want to be targeting something that no longer exists. And also, if you thought you didn't have a target a year ago, that cancer may have evolved a target now, because it changed, where there's a drug against it, which did not exist at the beginning. So I think the cancer evolution, we actually now have a way to measure it and detect it across time, and that's with these circulating tumor DNA tests. With that, I'd like to introduce my friend and colleague, Justin Hwang. His talk will be a lot more interesting than mine, and I hope I set the scene.
Hello, everybody. This is my first time at this particular conference, and I'm learning a lot as well. And I remember one of the words thrown out there was hope. And when I saw Emmanuel's slide, I was really hoping that he would talk because every slide was one word. I was like, oh my God. All right. All right, so now back to the serious issue. So I think Emmanuel brings me problems. I'm sorry, Emmanuel. And as if anything, what we discuss are a lot of issues that, for example, present to us. For example, some of the things he discussed are we don't know what all these genes do, even though we captured all this information. What if your cancer evolves? How do we deal with all these situations in real time? Because we can't just say, hey, this is a problem and not have a solution. And in order to have hope, I think we need to bring a solution to this audience. So I think this is at least what us and many others across this, honestly, this cancer research community are trying to do. So one of our aspects that we really try to focus on is really thinking about, as Emmanuel discussed, these genomic tests that are collected from the patients. Emmanuel has discussed how we can use this to interact with patients, potentially help your family, your children, to have preventative measures. But also at the same time, we need to think about, okay, what about those 99% of the genes that we have no idea what they're doing in the human cells? Because that is in part my job, to kind of figure that. I'm not going to win a Nobel Prize or 3, but I'm very excited about this work. My background is engineering. I love data science, and so this is a big data solution. Fortunately, today, we do live in an era in which we have solutions for data. So what I'm presenting here is, obviously, Emmanuel has talked about this. Unfortunately, I didn't stick with the 2-word slides today. With that said, you can kind of see that there are many avenues and we can collect tissue. And at the end of the day, Emmanuel has really thoroughly described this. I'm not going to repeat this, but every one of these entities on the right side that we're shown is a diagnostic company. They give us, as Emmanuel said, these sort of data directly from the tumors. There's so many entities right now, we partner with all of them here at the Masonic Cancer Center. Every one of these companies, as soon as the testing is done, they feed the data back to our cancer center. So this is great because it tells us we can get all the information that we'll need to potentially think about the solutions for each and one of our patients. However, there is a problem. The problem is that we really want to know more about the patients, but however, we're really dealt with about 1 million data points per patient. So to me, that is a daunting challenge initially, but it's also exciting too, because that means we have the opportunity to really think about how to utilize all this information to take us to the next steps in order to provide therapy. So I'm just going to share my thoughts about this. With all the information that is out there, how do we distinguish something of unknown entity, if it's cancer causing or not? On the left side, you'll see that we actually have information through just one consortium effort, data from about 250,000 of patients. And really, I want to thank our leadership for giving us the opportunity to think about this. Now, what do we do with this joint information? We can start asking, okay, of these 250,000 of patients, what are the genes that are actually causing and enriched or somatically altered in cancers? That allows us to say, okay, these are the genes, for example, in the case of the giraffe, that might cause the long neck, in this case, cancer evolution. So these are the genes that we can start focusing on to devise therapeutics against. So that, to me, is a little bit of a hope. And obviously, this requires a lot of data solution, as Emmanuel indicated, supercomputing. I'm not going to get into that today. But our solution is allowing us to interact with the data and also interacting with the data collected across the entire nation, across, at this point, even millions of patients. So we can start finding real solutions for our patients based on real genomic data. No longer just one gene like BRCA1, BRCA2. We can really start thinking of every single gene that is collected from these tests. Obviously, this is not an easy thing to do. I have a great picture with not just me and my wife. And, I started this field because my father also had cancer. We were on the first diagnostic test. And at the time, we didn't really know what to do. But now I think we progressed a lot. And this is why I care about these solutions. That said, it really requires a whole family. We see some of my great mentors are medical oncologists, phase 3 clinical trialists, really all together in one room. And here we see our data solution team with companies. These people in companies, they have families here too. They care about providing us parts of the solution because in part their families, may be affected with cancer as well. Then finally, down there is my laboratory that Emmanuel also co-mentors as well, which we see a whole team of people just really trying to come together to go through this cycle of, for example, collecting data, bring that raw data, billions of data points, and all this information from patients into our cancer center. And importantly, we need to do something about it. So we need to start thinking about what are patterns that we see. We have, for example, I'm just use the word out here, AI, machine learning. It sounds very complicated. It really kind of is. But what it does, it helps us recognize patterns that are consistent and recurrent in these patients that we collect. That allows us to bring into real world solutions that hopefully one day, not today, but very soon, we can interact with the patients and tell them that there's something that we can do about the cancer's evolution or the problems that we're seeing based on the genomic testing. With that said, we have a very robust effort. This is not to say that, we're better than anybody else. We're part of this collaborative process. Every year since Dr. Antonarakis has gone, he's been spearheading this effort really to help us collect samples. Every year you can see the exponential sort of increase in our sample collection. Almost a lot of our oncology groups are buying in. We're saying we need to do this, particularly as Dr. Antonarakis is, I recognize I'm using abbreviations that's maybe not super clear. On the right side, you can see we had the genitourinary group, the GU group. We have a very substantial data collection process that allows us to really hopefully turn this type of information into solutions for patients. And you can see our program is growing every single year. So to some degree, my trainees are telling me, Justin, what are we going to do with all this data? But at the same time, it's also a very exciting process. I think day by day, even week by week, we're starting to find new things that we've never seen before. My talk is relatively short as compared to Emmanuel. But with that said, what are we trying to do with all this information and essentially what we call translating this back to the patients? It is a daunting issue that everything that Emmanuel has brought up in the sense that we're collecting so much data, there's all these issues that we're seeing in a patient, the cancers can evolve, but how do we deal with all these issues with the data that we're collecting? For example, our lab itself, and in partnership with industry, we develop a lot of AI technology. This starts from the genomic testing data. That is our data that goes in the machine learning algorithm so that we can say, okay, what is coming together, for example, in prostate cancer patients that failed the therapy or responsive to therapy. These are the things that we can potentially do at this moment. In the middle panel, this really is a really innovative effort that is spearheaded. A lot of this is done at the University of Masonic Cancer Center. By knowing some of the genomic lesions, we can design utilizing all the technologies that are already available, that are orthogonally growing in this technical space to say, how can we devise, for example, immune-based therapies, other therapies that are more precise, as we discussed in the beginning of this talk. And lastly, see on the far right side, there are evidence that, for example, just based on genomic testing alone, we can see who is more responsive to therapy, who is less responsive. For example, in HR, what that means is a hazard ratio. I know I should have probably used a little bit more layman terms, but HR about 0.4 means you'll survive more than twice as long as other patients, even though you have the same cancer. All this information, sure, we should be worried that we have to do this test in the beginning. However, there is evidence that we can utilize to say, hey, there are some really good outcomes, either by, for example, learning more about the tumors, and giving the next generation of patients a better outcome, or say, hey, already right now, based on your genomics, you might already be more responsive to certain therapeutics. And lastly, for those groups that we need to really think about more carefully, there's significant efforts to already develop such therapies, such as I pointed out in the middle. This is a data slide from one of my best friends in the clinic that's really practicing these sort of therapies in our clinics today. So with that said, I didn't want to prolong this conversation, but I'm a person of hope, and I really think, hopefully this gives us a little bit of hope going forward to think that, yes, there's a lot of complexities in cancers, but there's also a lot of solutions based on what we have today. All right, thank you.
Thank you guys so much. So if anybody has any questions, you can raise your hand and then I'll come give you the microphone so you can speak up. And then also if we have online questions, we'll do those as well. So your hand first.
Hi, I really have two questions, but both involve collaboration. So with the private companies that you get the genomic information, is that pretty much all the private companies that are doing this, or is it like those 5 that you had listed? And then number 2, doing the research, do you collaborate with a lot of other universities trying to do the same thing you're doing, or is everybody doing their own thing?
We're going to tag team these answers here. We have to start small and then expand. So at the moment, we are not doing collaborations with every company. We're selecting about 4 or 5. And the way that we made that selection is our clinicians in the clinic, the oncologists, are only really using about 3 or 4 of these commercial tests. There are many reasons for that. Some are the cost of the tests, some are the willingness of the company to have a collaboration with us on research and give us the raw data. And some of the companies are just better than others. So there are some that have been left behind in the dust, so to speak, with less advances in the field. So it's not all the companies at the moment. What we're trying to do, though, is that we're trying to develop a portal whereby any company, if they want to work with us, can do so. So we're starting, let's say it's small, but we have the infrastructure in place to think bigger. Now, one of the important things that we did not talk about, which is a very, very important thing, is patient privacy and confidentiality, okay? When you get this genomic information, it's not linked to a patient name or address or date of birth or phone number. But some people can argue that because each and every one of us has a unique genetic code or genetic fingerprint, that even without any other identifiable information, no first name, no last name, no address, no zip code, that because every human being is unique, you might theoretically one day be able to match an actual patient just based on their DNA. And no one has actually been able to do that yet, but there's a theoretical consideration that this might be possible one day, and maybe a computer might be able to do it, artificial intelligence. And because of that, many states, including the state of Minnesota, have legal statutes, laws, that prevent us from doing certain things. So one of the things that we are prevented from doing is we cannot get raw data from any patient that is not a University of Minnesota patient. So if there's been a patient from Minnesota Oncology or Mayo Clinic or another state or another health system, we cannot, and we probably should not, be able to have access to that person's data because we were not their treating physician, and that data could potentially, quotes unquote, become identifiable one day. So that's a hurdle that we're trying to overcome, and we have some ideas how to do this without compromising patient confidentiality at all. And then the second question is about collaborations with other institutions. We are doing that, and I think at the moment we're collaborating with 5 or 6 other institutions. We want to make that more universal as well. One of the challenges is we don't yet have a common language and a common way to store these genomic data whereby the same platform can be used across sites. I think that is beginning to happen. There are some repositories that people are putting data into, which is a uniform. But at the moment, each site is using their own. Justin, did you have anything else you wanted to add?
Did anybody else have a question?
Thank you so much for making this understandable for me and hopefully other people in the room. So my question is, so should everybody go out and get genomic testing so that you can discover if somebody has a rogue gene? And so does this become a part of prevention in healthcare as well as treatment?
I think to me, the answer is yes. If my family member was put in that situation, I would think about this a little bit. However, I would also talk to an oncologist like Dr. Antonarakis about the situation that the family's encountering. And also because, as we don't know what is going on in about 99% of the genes. I'd be hesitant to say that, for example, if you see something, we should act upon it, because as you can imagine, there's a lot of noise or potentially false positives. We don't want to give people false alarms, and there's a lot of literature out there that might mislead people. So I do think that at a personal level, I think in the research-wise, if we're all thinking intelligently, I think that's a great thing to do. However, reality is, like, without knowing 99% of the information, I do think that it could potentially cause concerns in certain cases. So it's really to be interpreted with a lot of care. And as Emmanuel has indicated, even some of the world's experts don't even have this knowledge at this moment. So that's, I think, yes and no. All right.
I'll just add one thing. You know, you can't do it indiscriminately, and patients need to be counseled before doing it. And I don't think this can be done, you know, from a supermarket test where you go in and you buy your own. And the reason is the patient needs to be prepared to discover something that they might not want to know. And also the patient's family needs to know that they might end up discovering something that they wish they did not know either. Okay? So you might go in there, you know, looking for a breast cancer gene, and you might find out that you have an Alzheimer's gene. And you may not have wanted to know that you're going to get Alzheimer's when you turn 55. And all of a sudden, now you have this extra burden that you never had to worry about. Or you might find out that, you know, your BRCA1 gene is positive, but just having a mutated gene does not mean that you're guaranteed to get cancer. So if you have a BRCA1 gene, you've got a 70% lifetime risk of getting cancer. That's pretty high. You know, the chance of breast cancer overall in this population is about 20%. So it goes from 20% to 70%. That's almost a tripling, but it's not inevitable, right? And that means that 30% of people that have a BRCA1 mutation will live their whole life and never get cancer, even if they don't do anything. They don't have any screening, nothing, okay? So you need to be prepared for, you know, what am I going to do if I have a positive test? What am I going to do if I have a negative test? So I think if those conversations are had with the patient, and the patient says, yes, I think I'm okay with, you know, both scenarios. My family, I think, would also be okay if I tested positive. They would know that, you know, by default that they've got a 50% chance of also being positive. After that conversation, then I think, yes, many people, you know, could and should do it, but it does take some thought.
Thanks so much. I think this unfortunately concludes our first session. We have to give time for people to switch to the next breakout. Thank you all so much for your thoughtful presentations and conversations.